Good morning, good afternoon, good evening. How are you? I hope you are very good. Today, oh my God, it's so cold. I'm gonna get my tea, my jasmine tea. Yeah. And then once I serve it, I'm going to wait at least 2 to 3 minutes before I take a sip. But today, I want to bring a little information about myocardial ischemia, MI. What exactly does ST segment suggest when it is elevated and when it is depressed or in a depression? Not depressed because mental problem, okay? So we have one that goes up and one that goes down. That segment, that line that connects two waves. I'm going to talk about that later on. But when we are in school, sometimes we think that whatever we are being taught or what we get in school is going to be like hand in hand with clinical practice. Let me tell you, no, most likely it's not like that. Unless you got a good teacher that brings clinical science evidence base to apply to the psychology, to the science, to the physiology of the class that you are taking. When we talk about ST segment elevation, there is so many things that cause that I'm just gonna talk a little bit about it, and you're still gonna see that it is very important if you're passionate enough and if you love cardiology like I do. I'm not a cardiologist, I just love it. I teach cardiac monitor, I teach EKG, and I just love it, electrocardiogram. So, but I also want you to be aware of two things. When in a room, there is you, the healthcare practitioner, the nurse, the doctor, the CMA, the cardiac monitor tech, the LPN, the nurse practitioner, and the patient. There are two victims there. Two victims. Because we all know that history and physical examination is the number one thing you have to do, because that will actually dictate the test and the exams that you are going to do. But not everything you find it there. And there are some subtleties that we found in electrocardiogram that if you're not up to date with many things, it may bypass you. And that may cause either the wrong diagnosis, which normally happens. 20 to 50% of acute coronary syndromes are not diagnosed, are misread. One, by the system, the EKG software, the EKG machine, and second of all, because of the person who's reading it. Don't have a protocol, don't have standards, or just came new to this. We always are learning every day. Me, I'm learning every day. But I want I want you to understand one thing. There is a doctor that said something one time, and it was with me, it stuck with me like here all the time. And he's like, you never, there are two rules. You never are going to get every case, every 12 lead EKG properly diagnosed. And it's true. There is no way that you're going to do 100 electrocardiogram and you're going to be 100% accurate in diagnosis every time or in clinical impression. And he said also, but rule number two, you can never change rule number one. Meaning that you and we could always make mistakes. We could always misread an EKG. The system will always misread an EKG. Trust me on that. But we are going to talk about this. All right. I hope you like it. And let's see if there is something new that you, even I, are going to learn today. Oh, I got my hat. Why? Because trust me, it's so cold that my hair is like woo, like that. Ah, see you. Let me start by saying that I have no conflict of interest. Everything I do always has been for an educational purpose. Please, Even I'm going to bring, I get some image from Google, from the internet. I always put all my references, base, signs. So once again, not conflict of interest at all. This is all for educational purpose. Let me let me just tell you that when we in clinical look for signs and signals or symptoms that will let us be alert that the patient may be having a myocardial infarct, um, we always look for something that is known as ST segment elevation. So when we talk about ST segment elevation, I'm really talking, I'm going to see if I could mark it here so you could see it. If you look here, it says here ST segment elevation, and look at this part over here and at this part over here. So if something goes up, we call that elevation. Elevation. In this case, an ST segment elevation. And if it goes down, if this line here goes down, then we call that ST segment D depression. I think it's with one S. Okay. Now, the question is for all of you, because I just said to you that we all in cardiology, in clinical, in emergency, we look for an either elevation or depression of the ST segment. But do you know that there are so many arrhythmia that causes ST segment elevation, like an acute myocardial injury, global ischemia, early repolarization, myopericarditis, vasospasm, ventricular aneurysm, left bundle branch block, pulmonary embolism, when there is high voltage within cells membrane, like in left ventricular hypertrophy, like in Wolff-White Parkinson syndrome, like in electrolyte imbalance, like in hyperkalemia, like in hypothermia, like in hypercalcemia, also in intracranial abnormality. So there is a huge amount of things that could suggest specifically that there is an elevation ST segment. But I'm going to give you specific details based on the universal definition of myocardial infarction. All right? And that's what we are going to be getting into it right now. All right. All right. So the universal definition of myocardial infarction, I'm bringing it to you from, and they call it universal because Europe, United States, get together. European Society of Cardiology, the American College of Cardiology, the World Health Federation, and the American Heart Association, they all come together and they present their cases and they change or adapt or review whatever definition in terms of many cardiac pathologies. So they already have come together and specify the definition of myocardial infarction. But before I go there, I just want to let you know that everything I'm bringing to you comes from the American College of Cardiology, the World Health Federation, the European Society of Cardiology, and the American Heart Association. At the same time, because we're going to be talking about ischemia, we're going to talk about poor perfusion, we're going to talk about poor circulation, we're going to talk about atheromas or atherosclerosis or plaque or fatty acids just around the walls of the coronary arteries, the blood vessels that bring blood and oxygen to the heart. I'm going to explain to you first what is perfusion, ischemia, injury, poor perfusion. That's what I'm going to be talking to you now. So let me just go like this. Circulation, perfusion, we're talking about blood, we're talking about oxygen. So circulation slash perfusion, we're talking about blood, and we're talking about oxygen. At the same time, when we talk about oxygen, you know that is the air we breathe that has X amount of percentage of oxygen, and that you and I, without oxygenation, without nutrients, we will die. So when we have poor perfusion, we don't really want that. But just what is poor perfusion? Low amount of blood circulating through any given tissue. Like, let's say you tie your finger. You see that? What's going to happen if we don't untie that? What's going to happen in about 20 minutes, in about 45 minutes, in about an hour, in about an hour and a half? Well, you're going to start getting injury. The tissue is going to get injured. And as it progresses, it will get into ischemia, meaning that the tissue have not enough blood, not enough oxygen. You're going to start getting cyanotic, discoloration, blue discoloration. And if we don't fix that, it doesn't matter which tissue. It could be any tissue in the whole body organ system. What's going to happen is that necrosis may occur. That tissue will happen. And if that happens, that could happen in the brain, in the eyes, in the leg, anywhere that there is tissue. You're going to have an infarct. You're going to have a heart attack. You may have a stroke. So, poor circulation, not enough oxygen, obstruction in an stenosis, narrowing, when something is not really open enough to bring blood, to bring oxygen, nutrients to any given tissue, you are going to start having ischemia. Therefore, that tissue, that cell is not going to work properly. And that is one of the things that chelation does when in terms we are talking about calcification, plaque formation, hardening of the arteries, even in the small microcirculation, chelation will dislodge, will unblock that without you needing to go into a specific cardiology for a live procedure, an invasive procedure in which you have to open your body either through small incisions nowadays or to a big cut within your chest to open up those coronary arteries, those blood vessels in the case of the heart. So once again, poor perfusion, poor circulation, no good. Not only for your heart, but any body organ in your system. So if we are talking about, and I want you to understand this, if we talk about ST segment elevation, I'm going to show it to you again. You see that here? This is the ST segment right here. This is the baseline. You see that? This line here is the baseline. Anything that goes up will be an elevation. Anything that goes down, it will be a depression. You see that? So in an elevation, when we have an ST segment elevation, we classify that as an injury. As an injury, it means that something's happened. But if we have an ST segment depression, oh, it's with all S. Okay? Like in this case, that's just ischemia. And that is the problem. Now when we have ischemia, the damage is getting worse and worse and worse. So according to the universal definition of myocardial infarction, we diagnose a STEMI. A STEMI means ST segment elevation, myocardial infarct on a 12-lead EKG. It's when we start measuring the ST segment at the J point. That is how we classify, how we identify if there is a specific ST segment elevation. I'm just erasing right now. Now, normally, what we learn in school is that we have to measure two continuous leads, the ST segment, and that we really want them to be at a 1 millimeter in high. Like this little dot here is a 1 millimeter. Another one is a 1 millimeter. Another one is a 1 millimeter. Another is a 1 millimeter. So each one of these have 5 millimeters. Because one small little thing like this is equal to 1 millimeter. So if we have an ST segment that goes up 1 millimeter or goes down 1 millimeter, we're fine. We don't really care much about it. All right. Now, guess what? That's not really the truth in V2 and V3. Why not? Well, because in V2 and V3, if there is, for example, voltage abnormalities within your cell membrane, the heart cell membrane, in which there is a lot of voltage, okay, then you may have, like in left ventricular hypertrophy or in early repolarization, you may have an increase in that. That is okay. Those findings there are okay. But that's not the problem. The problem is that now we know that things have changed within gender and within sex. Meaning, if you are male in a specific age, you have to measure this amount of measurement, not 1 millimeter. If you are female with a specific age, you have to measure a specific measurement, not what is there. This is textbook. This is not clinical. What I'm bringing to you is what all this federation brought to us in terms of defining myocardial infarction based on an ST segment elevation that we're going to start reading from the beginning of the J point. The J point right here till here, where the T wave start. So where the S wave from the Q RS end, which we call that the J point, to where the T wave start. That's where we measure the ST segment, this ST segment. And this is what we call ischemia, which is, as you know, I said, in this case, you see that is changing here in color, in dark color, that's ischemia. How do we recognize that? By looking at ST segment depression. Remember, this is the baseline. Look how the S here and T here, the line that connect those two waves are below the baseline. Again, what is a segment? A segment is a line that connects 2 points, like from here to here. So the S wave end here and the T wave start here. If you see the ST segment depression, it means below the baseline is going down, and that suggests ischemia. Look how clean you could see it here. From the S and T segment below the baseline, all of this suggests what? Ischemia. What does that mean? That means that maybe one of the coronary arteries, the right coronary artery, normally we call it RCA, the left coronary artery, we call it the LCA, the circumflex coronary artery, or the left anterior descending coronary artery, which is the most common that we see around this area here when they get atheromas, arteriosclerosis, plaque in the coronary arteries. So how do we fix that? Either by surgery or with chelation. With chelation, we could go and clean those blood vessels, and that normally occurs within 20 to 30 or 40 therapies. That's what the TAC trial presented to the National Institute of Health and the American College of Cardiology and the American Heart Association and the European Society of Cardiology and the World Health Federation. So we are not talking about unscientific approaches, non-invasive. Okay? The only problem with this is that it is, sorry to say, but it's the truth. the pharmaceutical industry do not pay attention to preventive medicine. If somebody have this, no insurance will pay for this ischemia, for this fatal disease in which the patient will normally pass away. You think that's good? No, that's not good. So look what the new universal definition of myocardial infarct based on ST segment elevation represent. When I went to medical school, I did not know these values. Now, in men that are over 40 years old, if we see an elevation in two contiguous leads of more than 2 millimeters, that is considered already an ST segment elevation. And when we have an elevation, that means injury. So let me give you a tip. If in augmented vector left, you see an elevation or you see a depression of the ST segment in which we see the S and the T wave either negative below, that's an impending myocardial infarct because of an occlusion of the left anterior descending coronary artery. In another word, not only you're going to look at ST segment, but you're going to look at it in many different leads. And if in AVL you see something wrong, also in AVR, do not leave that patient alone. Do serial EKGs and you will understand. But that's only in men after 40 years of age. If the man is under 40 years of age, it's about 2.5 millimeters. Remember that 2.5, not 1 millimeters as it was before, is 2.5. But in women is 1.5 millimeters, not 1 millimeter. So let's go back. So in V2 and V3, we don't really look into that because when there is a high voltage criteria, like in left ventricular hypertrophy or in early repolarization, it is easily to see in both V2 and V3 an increase in the ST segment elevation. But in your case, in any other lead, if you see your patient, male patient, is more than 40 years old and he has more than 2 millimeters, you have to stop and do serial EKG. Do not let him go. If he's under 40 years old and he has 2.5 millimeters, do not let him go. Do serial EKG. Keep it for observation. If it's a woman and it's above 1.5 in any other lead, forget about V2 and V3, remember, in any other lead, but it have to be in a 2 or 3 or more consecutive lead, we see an ST segment elevation. That is already telling you that this patient has specifically or suggest injury. Something's coming. And we have to do not only an echocardiogram, but we also have to continue monitor our patient's stability, the circulations, the vital signs, the mean arterial pressure, everything we have to be on the lookout. Okay, so let's just check at this case. This is a 50 years old woman with chest pain, angina pectoris, retrosternal chest pain, and diaphoretic, meaning that the patient is sweating a lot, and at the same time is hypertensive. The question is this patient a good candidate for thrombolytics? What is a thrombolytic? Something that breaks blood clot, like a streptokinase. Okay, question for you again, is this real? Is this for real? An STEMI patient? What we want to give a streptokinase, because if there is a new clot that is being formed, it will break it apart. So once again, look at here at the inferior lead. Look at lead 3. Do we really have an elevation of the ST segment? Let's make it bigger. Now look at it. Can you consider that an injury? Can you consider that an ST segment elevation? Well, definitely yes. If you see it over here, if you see the baseline, let me underline the baseline. You see, this is the baseline here. You see that? Down here, the baseline. You see that? If you look at it in the second cardiac cycle, you could easily see an elevation of the ST segment. You see it here too? And not only that, look at the morphology of the T wave or the ST segment. It's supposed to be biconcave. When you don't have it biconcave and you have it the way you see it there, kind of like in a straight line, you see it here? It's going up. You see that? That's called a straight line. That is not good. So this patient had the criteria to be called injury, an ST segment elevation, or STEMI. Yes. Why? Because he's in a straight line going up, the morphology of the ST segment, and is more than 1 millimeter. Now, later on, 45 minutes later, an electrocardiogram was repeated. And look what we found. Again, look at the ST segment in the second cardiac cycle. Look at it in the third cardiac cycle in the inferior lead. This definitely suggests a left anterior descending coronary artery occlusion. This really suggests, remember, look how the QRS and look at how the ST segment is right here. You see that? When we have a morphology on the ST segment, as we showed before, in which is not biconcave, that is also another sign. So that we could see that we have an impending myocardial infarct that is about to come. That is one thing. At the same time, look at the ABL here. You see the ABL? The ABL has an ST segment downlope depression. You see that? That automatically, every time you see that the ST segment at the AVL is going down, that suggests an impending myocardial infarct. Those are two things that you could find easily, and that is the importance of having specifically a series of EKG. So this patient, we gave this patient thrombolytics. His troponin, his cardiac marker, or the cardiac marker of this patient was 56.96, and you know that the normal troponin levels are under 14. The good thing is that after 9 months later, an echo was done and the ejection fraction was 59%, which it was a good call, and it was good, and the patient was good, and everybody happy. But that was because why? Remember, we could easily see an ST segment elevation in the inferior leads. We could easily see the voltage. We could see the AVL, which it was showing on that 30 minutes, 35 minutes, 45 minutes EKG, that this patient was having an impending MI. But thanks God, we got it on time, and this patient is a good call, happy patient, a live patient. But when I'm talking about ejection fraction, what do I mean? Ejection fraction means the amount of blood that the ventricles is pushing out. Normally you want that to be between, let's say, 40 and 60. Let's say, but if you have below 40, you have a problem. It means that your heart, your ventricles are not pumping enough blood and oxygen to all your body organs and tissue, and you are going to have a syncope or heart failure. Okay, so like going back to blood tests, cardiac markers such as troponin, complete blood count, comprehensive metabolic panel, PT and PTT. Now, when we talk about the CVC, when we talk about the CMP or the CAM7, in phlebotomy, you need to understand that there is an order of draw. It's not that the purple goes first because it looks nice. No, there is an order of draw that you have to follow. And when we talk about CVC, we're going to be talking about white blood cells, hemoglobin, hematocrit, platelets. When we talk about chemistry, we're talking about sodium, potassium chloride, sodium bicarbonate, CO2, blood urea nitrogen, creatinine, and glucose. Those are things that we want to look when we suspect that our patient is having an MI. But in phlebotomy, you must follow the angle of inversion, 180 degree. Those tubes that has additive and anticoagulant, you must invert to 180 degree between 8 to 10 times. Those ones that do not have additive or anticoagulant, you could invert between 5 to 8 times, but to 180 degree. And the goal tap, you remember, you cannot centrifuge right away. You have to wait 20 to 30 minutes before you centrifuge. Remember that. And you need to have in mind that every time we use butterfly or a vascular access device, there is a high percentage of hemolysis. So if we have a hemolysis or a hemolyzed specimen, the blood test will not be that accurate.